Good morning and good evening, and welcome to everyone joining us from across the globe for this special session of AASLD 2024 highlights on the INEDSYS platform. I'm Dr. Sanjay Satpathy, and it is an absolute honor to open this event. Today, we gather to discuss cutting-edge advancements in hepatology and their practical implications for improving patient care. Our agenda today spans a diverse range of critical topics from hepatocellular carcinoma and AASLD to alcohol-associated liver disease and cholestatic liver disease and hepatitis B. These presentations will be led by some of the most distinguished experts in the field and moderated by an exceptional group of colleagues. As we proceed with these sessions, I request the moderators to introduce the speakers with a brief biography before their respective talks. This will not only highlight the remarkable accomplishments of our speakers, but also provide our audience with context on the wealth of expertise being shared today. I thank all our speakers and moderators for their valuable contributions to this event. Your expertise and dedication make this program truly exceptional. Now let's begin. I invite Dr. Prasoon Jalal to introduce our first speaker, Dr. George Therapundas, and guide us through the session. Dr. Jalal, over to you. Dr. Jalal is a Stan and Sue Party Professor of Hepatology at Baylor College of Medicine in Houston, Texas, in USA. Dr. Jalal.
Thank you, Dr. Satpathy. It's a really honor to chair this session, and thanks for organizing this update. As you know, INEDSYS is a very successful platform, and it's broadcast throughout the country and internationally, and has become a very important educational tool in a specialty. And thanks for bringing this cutting-edge update of the just concluded annual meeting of AASLD. Again, it's an honor and privilege to introduce Dr. George Therapundas. I was looking at his CV, and I don't know where to start. He currently he's the director of hepatology section, the chief in Oxnard Multi-Organ Transplant Institute in New Orleans. He received his medical training in University of Edinburgh and UK, as you know. And then he did his GI training in Edinburgh there, and then moved to Canada, Toronto, where he joined as a faculty. He did Masters in Public Health. Then he joined from Johns Hopkins. And also he was a faculty at University of in Toronto Transplant Center. And then I guess subsequently, apart from doing the Royal College degree from Edinburgh, he moved to New Orleans, which is closer to Houston. He's an expert in many areas, and today he's going to teach us about liver cancer, what we learned in our liver meeting. And his research interests is focused on a variety of areas, including transplantation and quality of life. However, today we are going to learn from him about the presentations we had in our current AASLD meeting a couple of weeks ago. With that, George.
Thank you, Dr. Jalal. I'll share my screen. Can everybody see?
Yes, we can see you.
So I'm going to focus on some of the abstracts and presentations that were given in San Diego. And I'm going to focus on 4 areas. There were so many abstracts to choose. I apologize if I missed anything important, but these are the ones that stood out to me as the most pertinent. I'm going to focus on a couple of abstracts that talk briefly about parts of epidemiology of HCC, then focus on a couple of other abstracts that show that statins may have a positive effect on HCC, then some of the treatments and associated complications, and some factors that may predict recurrence. So I'm going to start with the first abstract. This is data from University of North Carolina, presented by Dr. Moon, that discusses the trends in deaths from hepatocellular cancer. And these are national death certificate data. So we also have similar data in Louisiana showing that the rates of HCC, as you can see from the second graph at the top, well, the first graph at the top, appear to have plateaued somewhat. Obviously, there was a huge increase in death rates from HCC between 2005 to 2015 or 14, mostly due to viral hepatitis, especially hepatitis C. There seems to have been some plateau following that between 2015 and 2022. Obviously, that was also the COVID era, so there may have been some issues with identification of relevant HCC patients. But if what the investigators did, they adjusted the age-adjusted HCC death rates by etiology, and as you can see from the graph on the right at the top, the HCC deaths due to viral causes of liver disease significantly decreased over the following few years, although they still remain the predominant driver of HCC, both viral hepatitis B and C. It is worth noting that we are seeing an increase in HCC from other causes, namely MASLD and alcohol. And as you can see at the bottom, the colored graph, the annual percentage change in death rate is highest in the MASLD group, as predicted. So this was interesting that we have seen some plateau in the HCC deaths until now, but we have seen a change in the etiology of the underlying liver disease and the precipitating factors for HCC. And there are some other data from other abstracts that I don't have time to present here that do show some increase. There's some predicted increase in HCC with the predicted rise in prevalence of MASLD and alcohol. So the second abstract I'm going to present is an abstract from Stanford that showed that non-viral HCC is independently associated with poorer survival compared to viral HCC. This is a US population-based study. This cohort included patients over 67 from the SEER Medicare linked database. They used some ICD codes, and they analyzed 47,000 patients. As you can expect, they found a significant number of them had viral hepatitis, mainly hepatitis C. 43% had viral causes of HCC, and 57% had non-viral causes. The non-viral causes of HCC were older, they were more white, and they were non-cirrhotic. They had less surveillance, they had larger tumors, and they had more extrahepatic malignancies. The survival rates, it was worth noting. As you can see, these graphs show that the survival rates between 2000 and 2017 actually increased, but remained low. Both graphs show similar data. The survival rate started being around 12% and increased to barely above 15%. So survival rates have increased over those 17 years, but do remain low. What was interesting was that the non-viral HCC, those patients with MASLD and alcohol, were independently associated with a 30% lower survival compared to the viral hepatitis C patients. Of course, this may be due to a variety of factors. The 5-year survival for the viral patients was 16%, and for the non-viral patients was 12%. It is possible that some of the and it was shown in the abstract that some of the viral patients had more surveillance than the non-viral patients. So the non-viral patients would, for example, and we see this in our practice, they will turn up with a large HCC. Nobody even knew that they had significant liver disease or fibrosis before, whereas there appears to be more an increased recognition, obviously, of viral liver disease. So I'm going to switch gears here. The next two slides are going to be talking about the potential beneficial statin effect on HCC. This is an abstract from Dr. Elmazan from Boston, together with Raymond Chung. They used a case-control cross-sectional analysis using electronic health record data from the All of Us NIH Precision Medicine Initiative, and they included patients with fibrosis or cirrhosis, and compared those who had HCC to those who did not have HCC. They identified 94 patients with HCC. Their control group of patients with fibrosis cirrhosis who did not have HCC was 3,500. The HCC patients were older, 64 versus 58 years. There were more men in the HCC group, and there was more viral hepatitis in the HCC group. They analyzed the use of statins, and there is a table there that shows the significance there, but their conclusions was that statins were really associated with lower odds of HCC in participants with fibrosis or cirrhosis. Now, they did not have any data on the statin doses, the treatment length, or a lot of the details regarding the fibrosis cirrhosis. They did comment that lipophilic statins appear to show the greatest significance. Lipophilic statins are atorvastatin, simvastatin, and fluvastatin. But as you can see, the data is somewhat contradictory, because fluvastatin came up as non-significant in that chart. I presume the number of patients, they only had 94 HCC, so the number of patients that took the individual statins was probably quite low. Pravastatin, that is a hydrophilic statin, turned out to be significant. So there does appear some protective effect of statins in terms of developing HCC, but whether that's limited to a certain type of statin remains to be seen. The next study from Dr. Almari from a group from Madison, Wisconsin, again showed that statin use is associated with a low risk of recurrence of HCC after what was thought to be a curative RFA, radiofrequency ablation. So this was a single center retrospective study. They excluded any HCC recurrence or death or liver transplantation within 3 months of RFA. They had 300 patients, 37.5% were on a statin, and 62% were not. Again, they use this term, the CDDD, which is the cumulative defined daily dose. Those with a higher cumulative dose of a statin appear to have a slightly better or a slightly lower recurrence rate. So there's obviously some other data that goes along to suggest that there is a protective effect of statins in helping with preventing HCV recurrence or even the development of HCC. Next, I'm going to present a few slides on some of the newer treatments and associated complications. I'm not going to talk about any randomized controlled trials on these treatments, but I'm just going to talk about some of the factors that may predict real-world efficacy of etazolumab and bevacizumab in patients with advanced HCC. As you know, this is a relatively new treatment that's been shown to have beneficial effect in advanced unresectable HCC. Obviously, this is now an area that has been taken over by oncology. A lot of these treatments are not administered by us as hepatologists, so that they're treated by oncology which in the days of sorafenib and lenvatinib didn't happen as much. But there's certainly a much bigger involvement in HCC care from oncology. So the first study is a retrospective Korean study done between May 22 and June 23. They had 111 patients. The median progression-free survival was 6.5 months. Overall survival at 12 months was 79%. What they did show is that prognostic factors in terms of that could predict efficacy was the AFP levels, those who had combined radiotherapy, and peritoneal seeding apparently somehow prevented, suggested a better outcome, which is a little bit counterintuitive. The other interesting thing is that they also calculated the ALBI grade. This is the albumin to bilirubin grade, which does appear to predict a lower ALBI grade is more predictive of a better survival. This is another abstract that this is a systematic review and meta-analysis. This is a combined study between Dr. Sawapa and others from the US, Thailand, and it did carry out a systemic review and meta-analysis of the combination immunotherapy treatment with ATE and BEVA and compared it to sorafenib and lenvatinib. This combined 8 studies with a total of 6,855 patients with unresectable HCC. And they did show, and it's a little bit difficult to see, but you can see from the graphs in the middle that the ATE and BEVA groups significantly prolonged overall survival and progression-free survival in most patients when compared to lenvatinib. When they used the combination treatment and compared it to sorafenib, there was a benefit to the combination treatment in all groups. It was interesting that they found that the lenvatinib patients, because that were given this treatment for non-viral HCC, had slightly better outcomes with lenvatinib, which is interesting to see. One other important issue, though, is that there were a lot fewer grade 3 adverse events with the combination immunotherapy compared to lenvatinib and sorafenib. So their conclusion was that the combination immunotherapy treatment is generally slightly better for most patients, apart from the non-viral ones who may benefit from lenvatinib, but it was much better tolerated, which is certainly something we see in clinical practice. We are all aware that bleeding from atezolizumab and BEVA in these patients is a problem. This was a real-world Korean study, multi-center, 7 centers between September 2020 and December 22. It had 154 patients, mostly hepatitis B patients with some alcohol, mostly male, and mostly Child-Pugh A and B. They had a GI bleeding rate of 26%, with the majority of them, about 52% of those, due to variceal bleeding. Risk factors for bleeding were varices and previous variceal band ligation. So the risk of bleeding with ATEs and BEVA was also studied in a systematic review and meta-analysis, again from Korea. They had 28 studies, 3,895 patients, and the overall bleeding rates in this study were a little bit lower. They thought that their rate of bleeding was about 8%, so it's a little bit less than the single center or the smallest study from Korea that I mentioned already, higher up. But again, the majority of these GI bleedings were related to varices. Risk factors were an ALB grade 3 and a higher BMI. They also felt that the bleeding rate in the ATA and BEVA treated patients was higher than those that were treated with the tyrosine kinase inhibitor. And it was in the region of 5 to 18%, depending on which study you looked at. So, one more thing is that neoadjuvant therapy prior to transplantation for HCC. This study from the University of Pennsylvania looked at ablation and radiation that were thought to be associated with a higher complete tumor necrosis compared to chemoembolization. So the idea here is that if you can achieve complete tumor necrosis before transplant, you may have a better outlook. And it is true that if you look at some of the studies, the patients who achieved complete necrosis of their tumor pre-transplant had a higher 5-year survival. In this study, the 5-year survival of the patients that they looked at was 78% in those who did not have a complete necrosis versus 82% in those who did achieve complete necrosis. So the benefit is small, but it's about 4 to 5%. So these authors used the OPTN database. They had 10,000 patients from July 12 to June 23. They excluded patients with a previous resection and those that did not have HCC on explant. And the majority of them, about 90%, received one or more liver-directed therapies before transplant. The majority of them received TACE, which appears to be the most common regional liver-directed therapy given in the US. Obviously, this is very center-specific. We all have different ways of treating the pre-transplant HCCs. Percutaneous ablation with various methods was 19%. Some form of radiation therapy is 14%. I presume that they didn't specify, but I presume that includes yttrium or external beam radiation. And 22% had multiple modalities of treatment. They did show that those that had ablation, presumably of somewhat smaller tumors, had a higher rate of complete necrosis at the explant. But they also showed that those who had radiation did do better than those who received TACE. So the probability of complete necrosis, the predicted probability of complete necrosis was 46% for ablation, 40% for those that received some kind of radiation therapy, but for TACE was 27% only. So this suggests that ablation for smaller tumors and or radiation therapy may be better than TACE that is used in most centers. Certainly in my center, we use Y90 a lot more than TACE these days, and we have our own data to show that we're quite effective. This shows you the relative rates. As you can see, the highest complete necrosis was achieved with ablation alone in all three types of in all three sizes, whether it was less than 3, between 3 and 5 centimeters, and multinodular. Radiation was second, with TACE always being the worst outcome. And I think that's all I have to say this morning.
Thank you, George. This is a very concise and outstanding selection of abstracts. With the interest of time, because we have got more to discuss in other areas, we'll limit questions to 1 to 2 questions from the audience. Please feel free to ask questions now. While we're waiting, I have one question. You showed non-viral HCC, their probably survival is poor, they're not well responsive to immunotherapy. Did anybody try to, the survival is poor maybe because of there's no good surveillance strategy for them, especially if they're non-cirrhotic. But did they have any mechanistic explanation why atazovir is not that effective in this particular group?
No, other than the fact that, as you said, it's lack of surveillance. These people tend to be more advanced. That's the only rationale behind it. Although there was some conflicting data that I think one of the abstracts that showed mentioned that those who had extrahepatic mets did actually better with atezo and beva, but that was the only one I saw that showed that.
Excellent. Any other question from anybody?
Yeah, Colombo, Milano. Good morning, everyone. Well, referring to the increased mortality rates in non-viral HCC, I think we should also think about the fact that the vast majority of non-viral HCC present with an untreatable disease, and therefore, even those cases in which ablation of the tumor have been successfully performed, they are more prone to die of hepatic decompensation over 5 years of follow-up. This has been clearly demonstrated by Dr. Chelsea in Journal of Hepatology this year, compared to viral-related liver cancer, who enjoy a better survival rate because of suppression of Hep B or clearance of hepatitis C. I think we should also mind about this. Thank you.
That's very good information. Thank you, Professor Colombo. Anybody else has any question?
I would presume, I think for the interest of time, we're going to stop and move on to the next talk.
Sure.
Thank you, Dr. Jalal, as well. And thank you for moderating this session. And now let us move to the next session. And I will invite Dr. Puneet Puri. Dr. Puri is a transplant hepatologist at the VCU and the VA Institute. Dr. Puri, over to you. Please proceed with the session.
Thank you, Sanjay, and good morning and good evening to everyone. And it's a great effort in trying to recap some of the top highlights of AASLD. And as all of you could recognize, there was a huge shift this year in presentations, largely over 50% of the presentations related to MASLD, and I have a distinct honor to present our distinguished speakers. First one, Dr. Jaydeep Bihari. He's a professor of medicine in the Division of Gastroenterology, Hepatology, and Nutrition at the University of Pittsburgh School of Medicine. He serves as the Director of Translational Research for Hepatology at the University of Pittsburgh, and as well as Director of UPMC Liver Steatosis and Metabolic Wellness Program. He also serves as the Associate Director of the NIDDK-funded Pittsburgh Liver Research Center. His clinical and translational research is focused on metabolic dysfunction-associated steatotic liver disease, and his research has been funded by the National Cancer Institute, NCATS, and the NIAAA. Over to you, Jaydeep, to see a focus on diagnostics and what's new at this year's AASLD in your perspective.
Thank you, Puneet. I appreciate it. Let me go ahead and share my screen. And if you could please confirm when you're able to see it.
Yes, we are able to see it.
All right, fantastic. So thank you again. I appreciate it. And I hope all of you are warmer than us in Pittsburgh. It's 20 degrees Fahrenheit or -6 Celsius for us here this morning. So I hope all of you are in warmer places than us. So I have in 15 minutes a very task of trying to summarize what I stopped counting after about 75 were the number of abstracts focused on diagnostics and detection of MASLD and staging of MASLD. So I'll try to stay within my 15-minute limit and hopefully have some times for questions. So I will focus on four things. I just have a very brief preamble on what I thought were the diagnostic and emerging themes. There were so many abstracts. It was really hard to try to pick the best ones here. And I apologize if I'm missing some great abstracts out there, but I thought there were some very interesting themes and directions in which the field is moving. Then I've selected just a handful of abstracts that I thought were truly paradigm changing, and then a few open questions in future directions that I think we really should be thinking about in hepatology. So in terms of the scientific advances that are happening outside of diagnostics that I think are really shaping it is, of course, the 800-pound gorilla in the room, which is the very robust therapeutic pipeline and the approval of the first FDA-approved therapy, at least conditionally approved therapy for S-metron. So we'll hear from Dr. Fuchs next about that. But I think this is really important because that's put the pressure on all of us to try to identify patients who would benefit from these therapies. And so looking at approaches to identifying them, I think, will be very important. It's also important that the field, I think, is moving towards from histologic criteria towards non-invasive tests for predicting hard clinical endpoints, things that truly matter to our patients. So I think we'll start to see more and more interest in that space. The new nomenclature from 2023, especially the MASLD-MET-ALD divide, I think, or continuum rather, is really shaping the field also. And I think some of our diagnostics should move in that direction. I think Dr. Kulkarni will talk about ALD, and I'm not going to focus so much on MET-ALD today, but purely on MASLD. What's also obvious is that our currently available NITs do have some limitations, whether it's age and FIB4 or elastography and high BMI. And then there's issues with cost and access for MR elastography. So I think we've got to start to think about newer ways of risk stratifying patients. And finally, there's lots of excitement on omics-based technologies. And of course, AI and ML, which was the big theme. I counted over 100 abstracts in all aspects of hepatology focused on ML. So jumping into a few abstracts, this is abstract number 1. So presumably the highest rated, highest ranked abstract, which is a part of the presidential plenary, is from Dr. Miriam Voss's group, clinically distinct metabotypes of pediatric MASLD and unsupervised machine learning analysis of children enrolled in the NASH CRN studies. And the basic premise of this abstract is that there is phenotypic heterogeneity in pediatric MASLD. We know it's also true for adult MASLD. And the goal here was to identify metabolic subphenotypes or metabotypes in pediatric MASLD. And this is a concept that exists in other diseases, particularly in pulmonology, especially in asthma. They have asthma endotypes, which are related to immunologic subclasses. And so here they looked at over 500 children enrolled in the NASH CRN studies, and they used several clinical variables which are related to the definition of MASLD, so blood pressure, waist circumference, BMI, etc., biochemical features, as well as HOMA-IR for insulin resistance, and combined that with metabolomics. So very innovative and novel way of approaching subphenotyping. And what they identified were 3 subphenotypes. One was an early mild phenotype, which is about half of the pediatric population. And they had low lipids, low enzymes, low insulin resistance compared to the other 2 groups. One of them was more metabolic syndrome phenotype. So this was adipolipid systolic blood pressure phenotype that had higher clinical features, including obesity, waist circumference, blood pressure, as well as lipid profile. And then a minority of patients, but really important subgroup, which is the inflammatory fibrotic phenotype. And remember, these are all pediatric patients. So it's not like they've been sick for a longer time, but they had the highest levels of liver enzymes and fibrosis, suggesting that they're just going down a different clinical pathway. And these subphenotypes are associated with specific glycerophospholipid and bile acid species. So this was a very fascinating study. And I think this really should be repeated or at least looked at in adult populations also, and of course, replicated in larger pediatric cohorts. But I think this was a very novel, paradigm-changing paper about how we should be thinking about risk stratification for MASLD in general. The next abstract is an abstract from Dr. Ray Kim's group, which was looking at better ways to risk stratify MASLD using simple clinical parameters. And this was a study entitled Steatosis-Associated Fibrosis Estimator, or the SAFE score, predicts liver and cardiovascular outcomes, a UK Biobank study. And here the premise is that we really need better ways to risk stratify patients non-invasively. And so here they looked at adding additional variables to the FIB4 variables, so ALT, AST, platelet count, but here they added diabetes and BMI and serum globulin. And as we know, type 2 diabetes and BMI are both associated with a higher risk of advanced or clinically significant fibrosis in MASLD. And so here the goal was to distinguish clinically significant MASLD or fibrosis, which is stage F2, 3, or 4. And here they looked at the UK Biobank, and their outcome variables were looking at major adverse liver outcomes, or MALO, and atherosclerotic cardiovascular disease, as well as all-cause mortality. And they found that about half of the patients were individuals in the database were classified as low risk according to the SAFE score. About 40% were intermediate risk, because remember, that's the group that needs additional risk stratification. And over 8% were classified as high risk. When they looked at FIB4 with the same cohort, they found that more individuals were classified as low risk, but a higher percentage were in the intermediate risk category, and a very much smaller percentage were classified as having a high risk. So there are some significant differences. And when they looked at OROX comparing SAFE with FIB4, it was more accurate. SAFE score was more accurate than FIB4 for both liver-related outcomes, atherosclerotic cardiovascular disease, as well as for death from all causes. So since it's so easy to calculate it by adding these additional clinical variables, if this can be validated in other cohorts and in prospective studies, I think will become a definite improvement over FIB4, which we all know has some significant limitations. Another very interesting abstract was from the Mayo Group and Dr. Vijay Shah. This is Caleri et al., which is validation of a natural language processing model for detection of advanced chronic liver disease. And I thought this was very fascinating because in the age of AI and ML, it introduces a very interesting new angle to how we do electronic health record-based analysis. So many papers have been published using ICD-9 and 10 codes. And what we don't include in those studies is taking physician notes, also data from radiology studies which have a very high subjective element. And so the purpose of this study was to really compare NLP-based identification of advanced chronic liver disease with ICD-based coding. So they used an NLP tool, which was called MedDagger, and they looked at radiology reports, so ultrasound, CT, and MRI scans performed at the Mayo Clinic. And they looked for these specific terms: cirrhotic liver, coarse and hepatic echo texture, nodular contour, cirrhosis, cirrhotic. And these are all terminologies that radiologists like to use a lot. Even we do, hepatologists, in our progress notes. And so the NLP tools were able to extract all of these and identify these words within these reports, buried within the body of these reports. And then they validated it against a blinded chart review, which was their gold standard. So clearly, if a human being can identify it, a hepatologist can identify it, then NLP certainly comparing well with it. And they compared it with the traditional way of classifying it, which is ICD-9 and 10. So they looked at a very large number of reports, over 77,000. And then they also did a blinded review in almost 1,000 of these by a person. So this was human curated validation of the NLP results and compared it with the ICD codes. And they found that, interestingly, the sensitivity of the NLP was higher than using ICD-based data extraction. And the negative predictive value was also higher than ICD-9-based data extraction, but the specificity and positive predictive value did not deteriorate. So it maintained its positive predictive value and improved on the sensitivity. So I think this is a very interesting way of looking at large data sets. And for those of us who have looked at these large health plan and national level ICD-based data sets, this becomes a very interesting new approach to look at the problem. The other abstract that I selected is looking at omics. And this was a multi-center study, which included Dr. Sanyal and the group from VCU and other centers in Turkey and others, looking at validation of a microbial signature for advanced fibrosis in a global multi-ethnic cohort of MASLD. And so we all know that MASLD and MASH has a very close association with changes in intestinal microbiome and dysbiosis. And there've been now a couple of papers, one from Dr. Lumba's group at UCSD, and prior to that from China, showing that there was a microbial signature associated with MASH. And here the goal was to take a multi-ethnic cohort from Turkey, Latin America, and Asia, and combine them with the US cohort to find a signature. And they had 300 patients with MASLD. These were all patients that had undergone a biopsy, and they were comparing early stage disease with advanced stage disease. And they used a linear discriminant analysis effect size for this. And what they found was that there were several species that were increased in advanced fibrosis. And they also found one species, a couple of species of bacteria that were decreased in patients that had advanced fibrosis. So this does validate some of the prior studies and also raises the very intriguing possibility that not just can these microbial species and this microbial signature be used for diagnosis, but also perhaps there is some mechanistic underpinnings that could be targeted for managing and treating MASH in the future. So I thought that this was also a very fascinating new direction of diagnostics that forces us to think about diagnostics in a very different way. Another very interesting paper was from Dr. Greg Eberson. Oral colate challenge test identifies MASH patients with F3 or greater fibrosis with greatest hepatic impairment who show the most benefit from short-term rencofilstat therapy. So here, this is an anti-fibrotic cyclophilin inhibitor. It's being developed for MASH-related fibrosis. And Dr. Everson has developed HepQuant, which is a non-invasive test, which is based on both liver function as well as portal circulation and shunting that happens as a result of portal circulation. And they used the HepQuant Duo test to study the effect of this anti-fibrotic therapy in patients with MASH. So they had 70 subjects. They had advanced fibrosis. They were administered this colate clearance test using HepQuant Duo-Q, and they looked at changes at 60 days and 120 days. And what they found was that there were some patients who had significant hepatic impairment. They had increased portosystemic shunting, that's the shunt fraction, and the DSI, which was the dysfunction of hepatic function. And they found that this anti-fibrotic therapy was associated in both the reduction of this dysfunction score as well as the shunt fraction, suggesting that there was an improvement in fibrosis and fibrosis-related hepatic architecture and remodeling. So again, I thought this is a very interesting way of looking at how do we do prediction and risk stratification in terms of therapeutic responses. So a very different way and a different paradigm of thinking about therapy. Another interesting study was from a consortium looking at prognostic value of a two-step approach in the identification of advanced fibrosis in 16,000 plus patients with MASLD in the VCTE prognosis study. And here they are testing in a prospective manner in a multi-center approach the AASLD recommended two-step approach, which is FIB4 followed by elastography by FibroScan or a transit elastography for screening for advanced fibrosis at the population level. And while the AASLD criteria were proposed based on expert opinion, this is an attempt to validate this prospectively in a multi-center study. And so there were 16 centers in several continents, and they were collected prospectively. And their primary endpoints were liver-related events, which is what we really care about. So an important study and a very large cohort. And what they found was that almost 18,000 people were screened, 16,000 plus patients were included in this study. And they found that simply by using FIB4, a majority of patients over 10,000 were in the low risk category. And interestingly enough, the liver-related events were very low. So at 3 years and 5 years, there was only 0.3 and 0.4%. In the intermediate group, there was a secondary risk assessment based on VCTE. These are the guidelines proposed by AASLD and AGA. And out of these 700 patients, there was a higher rate of liver-related events as well as hepatic decompensation. And then there was a high-risk group that went directly to outcomes, and they were almost an order of magnitude higher than those who were in the lower group. So the conclusion from this study is that this is an effective approach for population-level screening. They also looked at the Agile 3+ score and found there was no benefit to just using liver stiffness measurement by transient elastography. So this gives us some confidence that at the population level, this might be an algorithm that does have some strong evidence base to support it. Another interesting paper was enhancing prediction of moderate fibrosis or higher in mast cell patients for resmetirom treatment via a machine learning algorithm. And here, of course, is the motivation is the approval of resmetirom, and how do we find patients and how do we stratify them for therapy? And so they looked at a combination of transient elastography, and they used a machine learning model, which they're calling Aladdin, which is a machine learning advanced fibrosis in at-risk MASH novel predictor. And this was a almost 4,000 patient study from 6 centers. And then they used a second large cohort of over 1,000 patients for external validation. And what they found was that this was superior to using just VCTE-based indices. And they also found that if you were missing transient elastography-based liver stiffness measurement, then the machine learning model, just by using their other parameters, could predict outcomes. So another very fascinating way of dealing with the problem of how do you identify patients for therapeutic intervention. So to finish up, a couple of important questions I think still remain. I think these are all very exciting technologies, but we really have to think about costs. The drugs are expensive, and we certainly cannot make our diagnostics equally as expensive. I think the question of what's the best strategy for population-level screening still remains unanswered. I think we have to do a better job of connecting these NITs with hard clinical endpoints, especially after we start patients on resmetirom or a GLP-1. What we are starting to notice is lots of patients are now on incretin agonist therapies, the GLP-1s and the dual and triple agonists, which are coming. And how will these performance of these tests change as patients lose weight even before they see us, their fibrosis may or may not resolve? And so I think these are important questions that remain. And I think there are specific populations. There's a few abstracts that I haven't included because of time, where they're showing that perhaps some of these tests, such as the ELF score, may not perform as well in certain populations, such as Hispanic Americans. So I think that validation in different parts of the world with specific populations is very important. So I'm going to stop here, and hopefully we'll have a few minutes for questions. Thank you.
Thank you so much, Jade, for that phenomenal overview of diagnostics and covering it from a variety of angles. I'll open this for questions to the audience. Well, I'll start with the question in terms of, like, these are all, I think, your very first point for future thing like cost effectiveness, and second about like a population level, because if we see the distribution of population, it is pretty skewed for even F2 to F4 at a population level will be about 10 to 15% patients. And deploying tests to such a large level, including trying to ascertain the F2, which is still the holy grail, that F2, F3 are not as accurately identified with so many other variables. When you see the performances, most of these approaches kind of relate to performance metrics such as area under the curve or the ROC curves, essentially. However, if you see deploying those cutoffs in, say, for example, FIB4 greater than or less than 1.3, and then see the distribution, that does not look as impressive when that number is like 40-60 compared to like, oh, area under the curve being 0.75 or. So what are your takes on how to approach and develop a good companion diagnostics at a cost-effective way based on what you're seeing?
Yeah, so such a great question, Puneet. And I think, you and I have talked about this before, is that if your prevalence is low, then these tests may not perform as well or may not be cost effective. So I think the strategy to use a test which has a very high negative predictive value like FIB4 or SAFE scores, I think will be great at the primary care level, especially if it's embedded within the EHR system. And then the second stratification with something else which has a higher positive predictive, which has a higher ability to discriminate those who are in the intermediate category, I think will be important. But the second challenge, I think, is also the very limited availability of FibroScans or transient elastography, at least for us. The big cities have it. All these studies are coming from large academic centers, but I can tell you patients that come to see us from 200-300 miles away, there's no FibroScan between here and, probably Richmond, I think. I'm not sure how many FibroScans we'll find in this 4-hour drive. And the second question, of course, is that there are some serious limitations, even with these second-line therapies, such as BMI, high BMI, their performance becomes very, limited. So lots of questions remain to be answered. How well will the proprietary serum-based tests perform remains to be seen, I think. I think we're nowhere close to solving this problem.
In the same context, I'll make a short question as well. So I know that all the societies are pushing FIB4 because it's convenient, and FibroScan, I don't know why, because I've got issues, as you mentioned, for both. FIB4 is not very good for younger patient or older patient, and FibroScan is not very good for obese, real muscle patients. So I understand there are lots of literature focusing on first line, second line, doing these, but because this is the right platform, I think we have got bigger responsibility to come up with maybe one single unified easy test rather than the sequential tests. Both are not easy to perform, as you mentioned. Yes, and I don't know why they're pushing so much in FibroScan area, or you can say liver stiffness, the imaging, because it's really impractical to implement anywhere. I get patients from far parts of Texas. They said, well, the only test we can do is the fibro test. I said, do whatever you have at your disposal.
These are great points. Great points. I 100% share your concerns about TE. We use ultrasound elastography a lot, but I think we need a lot more validation for those proprietary algorithms that I feel have not been validated enough. And they suffer from the same limitations with high BMI. I think ELF score needs a lot more validation. And the goal should really be something like hemoglobin A1C, a single test for diabetes. Will capture a majority of patients who are at risk. The NIS2 plus score, I think, is very promising. We don't have access to it. It's not FDA approved. So let's wait and see how that starts to perform when we test it in the real world. But absolutely, a whole lot of more research is left to be done.
Excellent. Great presentation. Thank you.
That was a great presentation. Any additional questions?
I just have a slight comment question, which might be cynical in the grand context of how many MASL patients we see in general. At this point, considering unknowns about the meds, though they are much safer than, like, for example, what we do in autoimmune hepatitis, I just want to get your opinion. Isn't it that maybe at this point, still liver biopsy is the gold standard to pick someone who we are going to put on a medicine which has not been widely used before we just promote the drug? If you're treating someone's risk factor with GLP-1 agonists, that's a different story. But if you're going to put patients on these new drugs, the role of liver biopsy is still as the way to go until we learn more about non-invasive modalities.
Yeah,
I
that's
think
a
that, go ahead.
Sorry, Puneet. Yeah, sorry. A terrific question. 100% agree with you. I think the way what I'm seeing, at least in our health plan and our patients population, is that the use of incretin agonists is increasing very dramatically. And as soon as semaglutide gets approved within the next few months for MASH, I think the pressure to use liver-specific antifibrotic therapies will really lessen dramatically, I think. So for those very small subset of patients who may have lean MASH, or those who may not be able to tolerate or have a contraindication to an incretin agonist, will probably be the second line in that situation. But if someone has obesity or type 2 diabetes, the first line will obviously be an incretin agonist. And I agree with you. I still am using a lot of biopsies for my patients, but clearly it's not sustainable. So we've got to come up with some non-invasive tests.
Well, those were great questions. Thank you so much again, Jaydeep. And we may have some questions back after Dr. Fuchs's talk, so stay tuned. Now I have distinct privilege to again welcome another star speaker in our pipeline for MASLD, my very own boss, Dr. Fuchs, who received his MD and PhD from Albert Einstein School of Medicine at Ulm University in Germany. He subsequently spent 3 years at Brigham and Women's and Harvard Medical School in the labs of Dr. Martin Carey and Dr. David Cohen, studying on lipid transport across canalicular membranes of hepatocytes. In 1996, Dr. Fuchs returned back to Germany to complete his training in internal medicine and GI, next to establishing his own laboratory studying the role of intrahepatic lipid transport proteins for biliary secretion. His bench research was funded throughout his entire time in Germany by the German Science Foundation, the equivalent of NIH, initially in Lübeck and later in Ulm. In 2006, Dr. Fuchs joined the faculty at Virginia Commonwealth University as Associate Professor of Medicine under the leadership of Dr. Arun Sanyal. In 2012, he joined the Richmond VA Medical Center as full-time staff physician and was promoted to Professor of Medicine at Virginia Commonwealth University thereafter. At the VA Medical Center, he has led the hepatology section before his appointment as Chief of GI, Hepatology, and Liver Transplantation at the Central Virginia VA Healthcare Systems. So Dr. Fuchs also serves as the Director of GI Research at the Richmond Institute of Veteran Research, or RIVER, and has built one of the finest clinical research operations in GI and hepatology within the VA health system. In addition, he serves the chair of MASLD subcommittee for the VA Field Advisory Board, which is a national board, and advises the Veterans Integrative Service Network Vision 6, covering Virginia and North Carolina in all aspects of GI and hepatology. So I welcome Professor Fuchs for showing us his thoughts on drug therapy for MASLD from TLM 2024. Over to you, Dr. Fuchs.
Thank you very much, Puneet, for the kind introduction. So at the liver meeting, as you mentioned, there was a large number of presentations that were covering MASLD. And for today's brief presentation, I've chosen to showcase some highlights specifically related to the drug development in MASLD. It's a disclosure slide, and I'm not presenting the opinion of the government rather than my own. So to set the stage, this slide displays the current drug approval pathway for MASH with fibrosis. So if a compound seeks professional approval by the FDA, two accepted surrogate endpoints need to be met. And those are histological endpoints. One is MASH resolution and no worsening of fibrosis, and the other one is one-stage fibrosis improvement and no worsening of steatohepatitis. Once these criteria have met, then professional approval can be requested, and if approved, like in the case of resmetirom, we have a drug available for prescription. Nevertheless, in order to obtain full approval by the FDA, one needs to demonstrate proof of clinical benefit, and that is done by extending the phase 3 study into a phase 4 study for another 4 or 5 years. So that's the background for a couple of compounds I want to discuss today. So the first class of compounds I want to discuss are the thyroid hormone receptor beta agonists. And the mechanism of action of those compounds is through or in general are through two receptor isoforms. The alpha isoform, which is responsible for systemic effects, and the beta isoform that in this case is particularly expressed in the liver and responsible for the liver-specific observations and effects that we have observed or observe in the case of AASLD and MASH. And the first drug that was approved earlier this year, as you all know, was resmetirom for MASH fibrosis stage 2 and 3. So of the abstracts, I want to highlight two compounds. The first one is a further analysis of the MAESTRO-NASH registration trial using resmetirom. And the second one is a new thyroid hormone receptor beta agonist, BK2809, explored in a phase 2 study in the Voyage trial. So this briefly highlights the way the MAESTRO-NASH phase 3 trial was set up. You had 3 arms, 1 placebo and 2 with 2 different doses of resmetirom. Resmetirom is a small molecule that can be taken orally once a day and has shown to have an excellent side effect profile and also improves the LDL cholesterol levels. So the study went on for 52 weeks. That's when the first analysis based on biopsy was done. And then is still ongoing for another couple of months to show basically clinical benefit. Many sites involved worldwide, almost about 1,000 patients that were analyzed for week 52. A classical profile, 70-year-old of age, high percentage of diabetes, hypertension, and dyslipidemia, and about almost 2/3 of patients had F3 fibrosis. And among the 3 different arms, 12 to 16% of patients were already on a stable dose of semaglutide, defined as being on the drug for at least 6 months. So this study further looked into the effect of weight loss and if patients were or were not on GLP-1 drugs in terms of histological endpoints with regard to NASH resolution and fibrosis improvement. So overall in this study, 14% of study patients were on a stable GLP-1 therapy for the diabetes indication, and the dose was usually semaglutide. The GLP-1 use was semaglutide, and the dose was 1 milligram subcutaneously once weekly. What they found is that GLP-1 use was actually not associated with weight loss, while it confirmed that a weight loss of greater 5% did improve liver health evidenced by liver biopsy endpoints. And importantly, GLP-1 use did not improve liver biopsy endpoints. So that, first may suggest to you that combining GLP-1 and resmetirom has no additional benefit in terms of histological improvement. However, we have to consider that semaglutide was used here at a dose of 1 milligram once weekly, and I'll show you shortly that this likely is a too small dose in order to have any benefit. So I think we still can consider GLP-1 use as a combination with resmetirom in the future. So the second compound I want to briefly highlight is VK2809. That was a phase 2b trial of a small molecule prodrug that is then converted in the liver to a potent beta receptor agonist. Also can be applied orally, good side effect profile, and similar like resmetirom have been shown to improve the LDL cholesterol level. So in this 5-arm study, almost 180 patients were enrolled, about 44% were diabetic, and 75% had either F2 or F3 fibrosis. The first endpoint that study was looking, that was the primary endpoint, was at week 12. And one was looking at the improvement in liver fat assessed by MRI-PDFF. And as you can see on the bottom, compared to placebo, there was a significant drop in liver fat among all doses of the drug at week 12. And that fat reduction was across all fibrosis stages, and it was independent whether the patient had diabetes or not. And further analysis showed that this reduction in fat was maintained until week 52. So the secondary endpoint of that study at week 52 was to look at histological improvement, and again, particularly on those surrogate endpoints that can be utilized for a conditional approval when filing with the FDA. On the left side, you can see that all 4 doses of the compound showed a much higher resolution of MASH with no worsening of fibrosis. And actually, if you compare it, even if the direct comparison is not appropriate, but it suggests that it is more potent than resmetirom. Same on the right side, all 4 doses showed higher fibrosis improvement without worsening of MASH. But here, the difference to placebo certainly is smaller than for resolution of MASH, and more in the range what we have learned from resmetirom. So the second class of drugs I want to discuss briefly are the glucagon-like peptide 1 receptor agonists. And this class of drugs is approved already for the indication of type 2 diabetes and obesity. And the direct effects on a variety of other organs displayed on the left side are contributing to the improved liver health in MASLD. So this was already mentioned before. So the liver meeting basically showed the ESSENCE trial outcomes that have been used for, or that will be used for FDA filing. So this is the study design of the ESSENCE phase 3 trial. You have basically a 2-arm study. Both received the standard of care, and the semaglutide arm had a 16-week induction or dose escalation in order to get to 2.4 milligrams subcutaneously per week. So that is substantially higher compared to what people were using in the resmetirom trial. So the study enrolled about about 1,200 patients, and the first portion until the interim analysis included 800 patients. Nearly 60% were diabetic, and about 70% had F3 fibrosis. And those are the most prominent important outcomes of the study. On the left, you see the impact of semaglutide on fibrosis improvement with no worsening of MASH. And you see an increase of about 15% over placebo, which was significant. And on the right side, you see the effect of semaglutide on MASH resolution with no worsening of fibrosis. And here the effect is much more pronounced and obviously also statistically significant. So this data basically support the filing of the compound for provisional approval with the FDA, and a decision is supposed to be done sometime, probably in the first half of next year. But what you can see is that the effect on MASH resolution is much more pronounced compared to fibrosis improvement. So the third class of drugs I want to highlight are fibroblast growth factor or FGF21 analogs. And this class of drugs does not only possesses antifibrotic mechanisms in the liver, but also improves metabolic health due to its pleiotropic effects on a variety of organs displayed here. So I want to highlight two compounds. The first compound was studied in a HARMONY study, and which is efruxifermin. And the second one is efimosfermin alpha, studied in a phase 2A study. So this is the HARMONY phase 2B trial exploring efruxifermin, which is a bivalent IgG1 FGF21 fusion protein that has a very high affinity for FGF receptor 1C, 2C, and 3C, and as well as to its co-receptor beta-clodo. Importantly, the compound does not activate FGF receptor 4, and therefore no off-target effects are observed. The half-life of that compound is 3 days, so that it's required to be administered once weekly subcutaneously. So in this study, 128 patients were enrolled, 3 arms, 2 different doses of the drug, about equal distribution of participants in each of the arms. 65% were diabetic, a little bit more females than male. And again, here, very high proportion of patients with F3 fibrosis. And this study, in addition to standard pathology, also used an AI-based digital histopathology approach. So this slide shows you the outcome of that phase 2B trial. So on the left upper corner, you see that fibrosis improvement with no worsening of MASH occurred already after week 24 in both arms that used efruxifermin, and after 96 weeks, it was a significant increase over placebo. So a difference about 50% improvement over placebo, substantially more than seen for any other drug class so far. And if one is doing a more refined analysis in terms of fibrosis, looking at a 2-stage fibrosis improvement, you can see that the higher dose of efruxifermin achieved that in about 36% compared to almost nobody in placebo. Also pretty impressive data. And not surprising, you also see for the compound at both doses a significant increase in MASH resolution with no worsening of fibrosis, as displayed on the left lower corner. The study also explored different definitions of histological outcome, and that is displayed on the right side. They defined a new term of partial reversal, substantial reversal, and near complete reversal. And what I think is impressive that if you look at patients that normalized entirely their liver fat, had a resolution of MASH, and improved from F3 to either F1 or F0, that happened basically in 30% of patients on efruxifermin at the higher dose. Now, we have to state something about the tolerability of that compound. As shown for other compounds as well as incretins, we mostly observe GI side effects. In this case, diarrhea, nausea, and increased appetite. And as you can see, if you go higher with your dose, those side effects are increasing. And there is, at the higher dose of 50 milligram, potentially an important number of patients that need or were forced to discontinue drug due to those side effects. So that needs to be, observed in more detail in further studies. So the other compound I briefly want to mention is efimosfermin alpha, also a fusion protein, similar characteristics for affinity for the FGF receptors. The difference here is that this compound has a half-life of 21 days and may make it more attractive because you only have to inject it once per month. So in this smaller study, including 84 people in 2 arms at a fixed dose of 300 milligrams efimosfermin, including 57% diabetics and a smaller proportion of patients with F3 fibrosis. You can see on the table on the right side that those patients on drug had a twice as high improvement in terms of fibrosis improvement and in terms of mass resolution, supporting further development of that compound. Now, I want to highlight one more thing, even if it wasn't demonstrated at the liver meeting, but it was shown earlier in the year at EASL, and that is another compound in this class, and that is pegozafermin. That has a half-life of about 4 days, similar like the efruxifermin is applied once weekly. And in this phase 2 ENLIVEN study, the primary endpoint was assessed at week 24 in terms of histological outcomes for 3 different doses. And as you can see here, that in terms of fibrosis improvement, there was significant improvement over placebo in the 2 higher doses of pegozafermin. And on the right side, even more dramatic improvement with regard to mass resolution, and here in this case for all 3 doses. So basically the efruxifermin and the pegozafermin are currently evaluated in ongoing phase 3 trials. So I hope that in the short period of time, I was able to convince you that the field of MASLD therapy is very rapidly evolving, and the future for liver-directed therapy for MASLD looks bright. Thank you for your attention.
Well, that was a fantastic overview, Dr. Fuchs, covering the hottest of the drugs in pipeline, including the ones that are approved and how the potential of combination therapy be there. While we're waiting for any question, I think we'll restrict it only to one question at the moment, given the time constraint, with open to ask after the end of the talk. Any questions, or I can ask one? So in light of what Dr. Bihari just highlighted about the metabotypes, it certainly looks like the heterogeneity in MASLD population exists. So would there in future be likelihood that who classifies into which metabotype may benefit with what kind of a drug? Could that be something that you envision, or how do you think that with the new ESSENCE trials, hot results, how that may interplay with the existing approved drug?
Yeah, that's a good question. I think, we need to be better in phenotyping our patient population, because we are not dealing with, one size fits all scenario. And that may be the reason why some of the prior compounds, may have not been successful to be moving forward in more advanced phases of investigation, because just the wrong patient population was selected. I think that is one thing. And then I think also that the future therapy needs to look into whether you have a predominant fibrotic disease, or whether you have a potentially more dominant metabolic disease, and therefore you have to utilize the drug or drug combination that you're using for therapy. However, that also requires that we are getting much better in diagnostics to identify those and categorize those patients. So a lot of work to do.
Absolutely. I think I would thank you and Dr. Bihari for such an outstanding overview and coverage from TLM 2024, and back to Sanjay.
Thank you, Dr. Puri and Dr. Fuchs, for this wonderful session. Now, may I have the honor to invite Dr. Masumi, who is going to introduce Dr. Anand Kulkarni, our next speaker. Dr. Masumi is the clinical director in hepatology at the Lenox Hill Hospital in New York. Dr. Masumi.
Sorry for the delay. Do you hear me, Sanjay?
Yes, we can hear you very well.
Okay. So just to put it into perspective, in 2023, more than twice the number of people, the number of people who passed away in America from effect of alcohol was more than twice the number of Americans died in the entire Vietnam War. Obviously, not all from the liver disease, but there's obviously a significant need to learn more about the liver associated, the alcohol associated liver diseases. And I guess no one could be better than Dr. Anand Kulkarni to give this session. Dr. Kulkarni is a senior consultant and director of critical care hepatology at the Asian Institute of Gastroenterology, Hyderabad, India. He has completed his Doctor of Medicine in Hepatology and Liver Transplantation from the Institute of Liver and Biliary Sciences, ILBS, in Delhi. He was awarded 3 times from AASLD in 2017, 2021, and 2022. He has more than 140 PubMed indexed publications to his credit, and is a reviewer and editorial board member for many national and international journals. He was recently named among the world's top 2% most cited authors. His main areas of research focus include alcohol-associated hepatitis, ACLF, HCC, and liver and live donor liver transplants. Dr. Kulkarni, thank you so much for joining us.
Thank you so much for the introduction. Kind introduction. Am I audible? Hello.
Yes.
Yes, you are.
Yes. Okay. Yeah. Thank you, Professor Satyapati, for asking me to talk on alcohol-associated hepatitis. I'll be just touching upon the diagnosis, the presentation, management of the disease, novel therapy which have been presented, and few abstracts on alcohol use disorder. I think this is the first one. We know that traditionally we all use the INEDSYS model for diagnosis of alcohol-associated hepatitis. But this was a multi-sample study including 90 patients with alcohol-associated hepatitis and 467 patients with alcohol-related liver disease. The gold standard they considered here was the ballooning, the presence of myelinated antibodies, hepatocyte ballooning, and glomerular inflammation on biopsy, or the liver extract. They were again randomly split into training set and the derivation and the validation cohort. What they noted here was this new model, the AHEAD model, that the area under the curve was much better than the traditional INEDSYS model, which was 0.59 compared to here, which is 0.69. And the p-value was significant. Using 50% probability cutoff, the specificity and the sensitivity of AHEAD model were 61% and 63% respectively. And similar findings were noted in NIAAA model, which was 54% and 63%. What actually is this AHEAD model? This is a model based on AST, the AST-ALT ratio, serum bilirubin levels, and which is compared to the currently used NIAAA model. And they said that this is much superior to diagnosis of clinical diagnosis of alcohol-associated hepatitis rather than using NIAAA. Although this needs further confirmation for the studies in larger sample size, the proportion of patients with AH here is only 90, which is much lesser than what we actually see in clinical practice. The second criteria on clinical presentation of the diagnosis, it's a very tricky question to differentiate alcohol-associated hepatitis and ACLF due to alcohol. This was a multi-center prospective cohort study of about 646 patients, 24 centers. Age was around 50 years. 85% were men, and life score was 25. 46% had use of corticosteroids. The most, this was probably based on the EASL criteria of ACLF. 57% had ACLF diagnosis. And almost 40% had grade 3 ACLF, only 20% had grade 2, and 10% had grade 1. You see the organ dysfunctions in this, liver was the commonest one, followed by coagulation, brain, renal circulation, and lung failure. Based on this presentation, what they reported was patients who had no ACLF or patients who were grade 1 and grade 2, they had better survival compared to grade 3, whose survival was very poor at 180 days, that is 6 months. So multivariable analysis adjusted for age, BMI, and the MELD score, patients who present ACLF3 have poorer survival compared to those who do not have ACLF or have ACLF1 or 2. The that ratio was 2.67 and it was quite significant. Authors concluded that in patients with alcohol-associated hepatitis, only ACLF grade 3 is a major determinant of mortality. And patients who fulfill the criteria should be promptly referred for early transplant for the input to the survival of these patients. The next clinical aspect of alcohol-associated hepatitis was this study from Japan, where the title of the study was BMI influences the outcome. Basically, they included 104 patients, and 27 were related to liver-related death, and 10 had other causes of death. Here, the endpoint was risk factors for all-cause mortality, risk factors for liver-related events. When they did the multivariate analysis, what they found for BMI, the presence of ascites, high bilirubin levels, and continued alcohol intake were predictors of all-cause mortality. Similarly, patients who had high BMI, who had ascites, and high bilirubin were the patients who had liver-related mortality. So this is clinically very relevant. We see these patients very often, that patients who have ascites, they do not do well, they do not tolerate any kind of medical therapies. Patients who continue to drink alcohol, again, have very poor outcomes. And one unique thing what was noted here was the presence of high BMI. What was the BMI cutoff when they said here was 25. Any patient with alcohol-related liver disease or probably AH with a BMI more than 25 is very often seen in these days with the overlap of our current alcohol steatotic liver disease these days. We see that the outcomes of these patients will be pretty poor. They continued drinking ascites. They concluded higher BMI, higher bilirubin, and post-discharge continued alcohol intake influence the outcomes of these patients and increase the risk of decompensation. So this was a study from Canada. We know the STOPA trial, which had made a lot of news. It was the NEGM's publication, which said that corticosteroids have marginal benefit at 30 days, but no benefit at 90 days. Again, insufficient but no benefit at all. So this was a database study from Canada, where the study question was how has the study impacted the use of corticosteroids and pentoxicamine? And what is the real world efficacy of steroids in Canada? There are around 2,000 plus patients with alcohol-associated hepatitis who were hospitalized during this study period, and 1,000 odd who had met the criteria for MELD more than 21. With following this STOPA trial, they saw that the use of corticosteroid has gradually increased. gradually increased despite showing that there is no much benefit at 90 days. While the use of pentoxifene has almost become nil with time, although the 30-day mortality and 90-day mortality more or less remain the same. So despite having some negative effect, the use of these steroids continue to be used. And there was a recent publication in Lancet Gastro showing that 80% in US and UK still continue to use steroids as the first line therapy for alcohol-associated hepatitis. When they assessed the mortality at 30 days, there was slightly, that ratio had crossed to 1, it is 0.73 to 1.03. And the best effect was seen in patients up to 20 to 35. If you see 25 to 35, minus 3% mortality, at 95% going up to -1 to -6. At 20 to 25, minus 3%, and -1 to -5. But if the mild process 35, there is no use of using corticosteroids. Very important message saying that patients who have been planned for any trials avoid patients who have high mild. Since the summary of this basic study was there has been increase in the use of corticosteroids, although there is modest effect on 30-day survival, but no difference in 90-day outcomes. And there is some heterogeneity of response according to MELD baseline MELD score here. And you can see that patients should more than 35 should be avoided from all sorts of steroid therapy or other therapies for alcohol-associated hepatitis. To summarize, the use of corticosteroids is quite common. There may be some improvement in 30-day mortality, but patients have no effect on the steroid. The next study was from a multicenter study from India and Canada. This we included on this is called a STAT trial, that is standard versus tapering dose of steroids in alcohol-associated hepatitis. We included patients with age between 18 to 70 years and severe AAS dependent more than or functional and DF more than 32. They randomized to two groups, fixed dose versus tapering dose. Fixed dose received 40 mg for the first week, followed if they had responded, they continued another 40 mg for 3 weeks and stopped, which is the current guidelines. On the other group, they received 40 mg for 7 days. If they had responded, the dose was tapered over next 3 weeks to 10, 30, 20, and 10 and stopped. What we noted was the use of the tapering dose, the mean total dose, steroid dose was much lower, although the duration of therapy and the response were pretty high in both the groups. The incidence of infection in the whole cohort was 26%, which is similar to previous studies. Again, the median time to infection is 30 days, and there was much lesser incidence of infection like tapering dose than the fixed dose, which was 20%, 33%. With the use of antibiotics, there was reduction in the incidence of infections with the use of antibiotics, while in the tapering dose compared to those in the fixed dose where there was no much difference in the incidence of infections. There is no difference in the mortality at 90 days, and more the commonest cause of mortality was sepsis organ failure. There was a little decrease in the trend towards a decrease in the incident requirement patients of requiring hospitalization in the tapering dose, and the number of hospitalizations was low compared to fixed dose where it was on the higher side, but the impact on health score was similar. There was no much difference. All similar proportion of patients have achieved a mile less than 17 at the end of day 9. The rapid tapering of corticosteroids led to reduction in the incidence of infections, the number of hospitalizations, without any effect on survival or the score. The next study is the novel therapy, which has been, there are few studies, phase 1, which have been published, which are taken from the INEDSYS Gastro. This is last purpose form, which reduces the intracellular lipid accumulation by inhibiting the lipid biosynthesis and dampens the inflammation by decreasing the inflammatory mediator and improves the cell survival by suppressing the apoptosis. It inhibits the DNA methyltransferase, which have been increased in patients with alcohol-associated hepatitis. So this was a study of a randomized controlled multicenter study. There were around 307 subjects which are included in this study. This is the drug which is to be given parenterally. 2 doses, 30 mg and 90 mg, and the third group is placebo. Primary endpoint was 90-day mortality or liver transplant, and the secondary endpoint was mortality alone. And they include all the data, that is US and UK patients. A trend towards reduction in mortality was seen with 30 mg loss of cholesterol, but not with 90 mg. But when they included only patients with US data, they showed a significant difference in mortality. There was reduction in almost 57% 30 mg compared to 58% in 90 mg dose at 90 days. The reason for this was said to be the early initiation of the drug. In the United States, the median time to initiation of the drug was 5 days compared to 13 and 11 and 7 days in other countries. So the authors concluded that large cholesterol treated groups had better 90-day survival rates than placebo. One of the obvious regional differences is probably due to the number of days from hospital admission to the first dose, just shortest in US. So earlier initiation of treatment may have benefit in these patients. The second novel therapy which was presented was fecal microbiota therapy for patients with steroid ineligible alcoholic hepatitis, a study from INEDSYS. They included patients with 18 to 70 years with DF more than 80 and MELD more than 20. They were randomized in 2:1 fashion. The commonest reasons for ineligibility was infection or very high DF and the presence of acute kidney injury. This was a strict criteria to include a donor for a healthy donor. This was usually a first-degree relative who underwent multiple tests to identify an ideal donor for a stool for these patients. What they noted was with the FMT, fecal microbiota transplant, there was significant improvement in the 90-day survival, almost 73% survival with FMT compared to 40% in standard medical therapy at day 90. But the effect was not much at day 28. It was a trend towards significance, but not much. But at 180-day survival, again, that's not better with FMT, that is 60% versus 40%. There is also improvement in the MELD score with the FMC. There is also an reduction in the incidence of hepatic encephalopathy with FMT, which is not there with standard medical therapy. Again, fecal microbiota transplant reduced the risk of the alcohol relapse, which was not which was seen in around 3 out of 30 patients with fecal microbiota transplant compared to 6 out of 15 in the standard medical therapy. The authors concluded that the FMT is safe and effective in alcoholic hepatitis patients. It improves 90-day survival and 180-day survival, improves the MELD score as well. Coming to alcohol use disorder, the drug use of this drug, we all know that GLP-1 has rampantly increased in the recent times. This is the overall presentation database analysis of 14,370 patients with ALD and type 2 diabetes, of which 317 had GLP exposure. What they noted was patients who take GLP-1 had lesser incidence of liver-related decompensation, but there was no association between portal hypertension-related events and liver transplant. So using GLP-1 in patients who have diabetes and ALD may lead to reduction in the incidence of ascites and other complications, probably. But this was a database analysis which needs to be assessed in prospective randomized controlled trials. And the effect of naltrexone in this patient, this was an oral presentation from Dr. Vinay Bagradar, saying that initiation of naltrexone is associated with lower rates of acute kidney injury, spontaneous bacterial peritonitis in patients with decompensated alcohol cirrhosis and ascites. Here, this was a database study again. They included patients who had received naltrexone and compared with those who had not received naltrexone. 2,200 patients compared to 38,000. After propensity matching, they noted there is a reduction in the incidence of AKI, SPP, and mortality. So naltrexone in patients with MET ALD, again, a similar study which reported which compared patients who had exposure to naltrexone compared with those who had no exposure to naltrexone. 1,273 against 25,000 patients, and were followed for incidence of decompensated liver disease or deaths. And when they did a propensity score matching for the confounders, they found that naltrexone therapy resulted in the reduction in the incidence of decompensation of the cirrhosis. Again, naltrexone is excellent. There is good evidence, some evidence that support GLP-1 agonists for these patients with ALD, AUD, and alcohol-related cirrhosis. Only all the these are database analysis, none of them are prospective RCTs. There is one major caveat for these studies. The last studies were the use of vernicillin and tartarate. Here, 31 patients with met-ALD were given 1 mg twice daily of naltrexone vernicillin tartarate. This was Dr. Amit Singh's, Ashwini Singh's group. They noted that there is reduction in the craving for these patients. There is also improvement in the enzyme levels. There is reduction in the significant craving for this patient, but the outcomes did not differ much. But yes, they are shown that vernicillin tartarate may be beneficial for these patients with ALD in long run. This was one of the studies from our colleagues showing that 1/3 of living donors for recipients of severe alcohol-associated hepatitis experienced ecological distress. We assessed all the donors of alcohol-associated hepatitis who had donated for early for the alcohol-associated hepatitis. They are assessed in General Health Questionnaire. There are 19 donors who had consented, and women were around 48%. They were perceived relatives of these patients. Although 42% had no symptoms and were doing well, 32% had scores more than 23. That is, almost 1/3 had psychological distress, 2 required depression therapies following donation for alcohol-associated hepatitis. So in conclusion, we learned in this AASLD, there are ML models which are coming up against the traditional INEDSYS, which is the gold standard. Clinically, we noted that ACLF3 and high BMI have poor outcomes for this patient with alcohol-related liver disease. Corticosteroids continue to be treatment of choice, and rapid tapering is probably beneficial for these patients, which has been shown in large multicenter study. There are novel therapies which are coming up. Larsucosterol is one of them, and fecal microbiota transplant, which has been shown to be effective in few of the studies, but needs again validation across the world. For alcohol use disorder, we had naltrexone, GLP-1 agonist, and vernicillin showing benefits in some or the other way. But all of them are database studies and need to be done in a prospective or randomized controlled trial. I'll be happy to take any questions. Thank you.
Thank you so much, Dr. Kulkarni, for this excellent review of these high-impact studies. Any question?
So a quick question, Anand, that was an excellent presentation and great overview. In terms of the AHEAD model, right? And you see that they have used both AST as well as AST to ALT ratio, which kind of is a confounding. You cannot use in a model the same two variables that can interplay, right?
I agree. Excellent question, actually. To be frank, I went through that abstract twice or thrice. I tried to connect with the authors as well. I mean, bilirubin was not found, but there's multiple things which are not found. But the cutoff of these values have to be assessed in other patients also. And the number of patients included are only 90. So that might be a major limitation for us.
That is true. Small study. Good job. Yeah.
Dr. Kulkarni, I have a very quick question regarding your own study. In your group, when you tapered the prednisone quicker, did you see any difference in patients who fall into the category of not getting sicker but becoming more decompensated at the 90 days? Meaning some of these people get much better, some get much sicker, and there's a group who fall into that gray zone. Was there any difference between your two arms in view of decompensation, moving toward decompensated liver disease?
Excellent question. Thank you so much. There are no much difference in the episodes of decompensation. In fact, the MELD score change was similar in both the groups. But what we noted is that although the MELD score remained the same, the proportion of patients in tapering group had achieving bilirubin less than 3 was little low. That is the only thing which was noted in subgroup analysis.
Great. Thank you so much. We conclude this section. And again, thank you, Dr. Kulkarni, for excellent work.
Thank you so much.
Thank you, Dr. Masumi and Dr. Kulkarni, for this wonderful session. Now we'll move on to the next session, and may I have the honor to invite Dr. Monges Pagdala. Dr. Pagdala is a transplant hepatologist at Methodist Dallas Medical Center. Dr. Pagdala, over to you, and you can introduce the next speaker and moderate the session. Thank you so much.
Thank you, Sanjay, and thank you everybody for attending this session today. The last few years has been very exciting for non-alcoholic fatty liver disease, but I think the future in terms of therapeutic option belongs to cholestatic liver disease with some exciting therapeutic options that are available now. And using that segue, I'd like to introduce you to the next speaker. It's my distinct pleasure to introduce Dr. Brian Borg, a highly distinguished hepatologist and gastroenterologist with over 3 decades of experience in this field. Dr. Borg earned his medical degree from the Tehran University of Medical Sciences in 1992 and subsequently completed his internal medicine at Prince George Hospital, went to do his fellowship in Barnes-Jewish Hospital and subsequently transplant hepatology in NIH. Dr. Borg holds many prestigious positions in medical institutions in the past, currently the clinical professor at Tulane Medical School and also affiliated with East Jefferson Hospital in Louisiana. He has clinical expertise which broadly in different conditions in liver disease, including complex hepatobiliary diseases, chronic liver disease, and liver transplant. He's a dedicated researcher and educator and having multiple significant contributions in medical literature in this field. Today, we are honored to have Dr. Borg leading our sessions in primary biliary cholangitis and primary sclerosing cholangitis. With his unparalleled experience in managing this complex cholestatic liver disease, Dr. Borg will guide us to the latest updates of 2024 AASLD, highlighting advancement and diagnosis, treatment, and emerging therapies. Please join me in extending a warm welcome to Dr. Brian Borg. Dr. Borg, the field is yours.
Hi, Mangesh. Can you hear me?
Yeah, I can hear you well. Thank you.
Thank you very much for that introduction. Let me share my screen. So, it's a pleasure actually to present some of the most important highlights that we had at the liver meeting this year. And I have to say that it's very exciting to see that the field of PBC and PSC is becoming more busy. As you can see from, if you do a search of the liver meeting app, you will see 74 PBC abstracts and 98 PSC abstracts. But these did not even include the late-breaking abstracts that I'm going to be mostly focusing on. Some of the abstracts has been selected by Chronic Liver Disease Foundation are presented here. These are probably the most important ones. Obviously, there are other abstracts that have significance as far as the clinical contribution, and I apologize if I did not include them in this presentation. But I have to say that the most exciting thing that I've seen in this meeting from my standpoint, because of my interest in cholestatic liver disease, has been the two presentations of clinical treatment for patients with primary sclerosing cholangitis, which is a very significant unmet need in this field of hepatology. And it was exciting to see two new agents presented here. First of all, I have to thank Dr. Bowles and Dr. Cowley for sharing these slides so that I can present you today. So the first one is a product named CM101, Improved Fibrosis Biomarkers in Patients with Primary Sclerosing Cholangitis, the SPRING study. CCL24, which is an eotaxin 2, is a chemokine which is important for trafficking and regulates inflammatory and fibrotic activities through the CCR receptor. As you can see here, this product, which is a chemokine, is mostly released by inflammatory cells, but it can cause inflammation and fibrosis. And through more tissue damage and tissue repair, you will have more release of CCL24, and that can cause more inflammation and more fibrosis in a vicious cycle. And this directly activates fibroblasts, enhances local monocytes and macrophages, and drives self-reinforcing cycle of inflammation and fibrosis. As far as the background, the levels of CCL24 were elevated in patients with PSC. And in this slide, you can see that in healthy liver, as opposed to PSC level, you can see a significantly higher expression of CCL24 in the liver tissue of subjects with PSC. And serum level of CCL24 is also higher in cirrhotics and associated with the risk of progression to cirrhosis. So conceptually, it was a very good target to address in patients with PSC. As we said, the expression is significantly elevated in PSC liver, and therefore likelihood of the diminishing that or inhibiting that will be important in helping with resolution of inflammation and fibrosis, which is the underlying etiology or pathophysiology that you can see in patients with PSC. So CM101 is a humanized monoclonal antibody, neutralizes CCL24, and was well tolerated in multiple phase 1 studies that were tried in different clinical settings, including PSC patients. In patients in MDR2 knockout mouse, which is the lab model of PSC, it showed that it attenuated collagen deposition, and in the PSC patients, it reduced macrophage and recruitment in biliary epithelial cell proliferation. So there is a lot of scientific basis for such treatment. Therefore, in a spring study, a phase 2 randomized double-blind placebo-controlled study of CM101 in PSC patients, patients were enrolled in 2-to-1 kind of ratio of the IV treatments every 3 weeks of 10 milligrams versus 20 milligrams versus placebo. And the initial phase of the treatment for 15 weeks period that will be used that was used to present here the data were included, and the patients after the 15 weeks, they were all switched to open label phase, and they were followed after that for 12 more weeks, so overall to 48 weeks of trial. Patients with PSC were supposed to have large duct disease for more than 24 weeks of duration with alk-phos of more than 1.5 times upper limit of normal with stable IBD, and stable UDCA were allowed. And the outcomes were mostly the safety and tolerability. And the secondary outcome were changes from the baseline to week 15 in liver stiffness measurements, ELF score, fibrogenesis biomarker, which is PRO-C3, pruritus measurements, liver enzymes activities, as well as pharmacokinetics and pharmacodynamics parameters. Certain group of patients with VCTE of 8.7 kilopascal or higher were considered the more severe group, and we're going to discuss it there. And it's a multi-center trial that's done in US, UK, Germany, Spain, and Israel. And this is the baseline characteristics of the patients. It was pretty much balanced across all the groups. And as far as the safety profile, the product was relatively safe. As you can see, there is no significant difference between treatment emergent adverse events in different groups. And the rate of serious adverse events was extremely low. This is the results of the biochemistry test. As you can see, there was a change in alkaline phosphatase of about 2.5% from the median at the higher dose, as well as ALT, AST, and GGT. There was also a moderate, in the patients who had a moderate to advanced disease with liver stiffness measurements of 8.5 kilopascal or more, there was more pronounced actually decline noted. So it suggests that this disease they suggested that this product can impact positively even in more severe cases. The total bilirubin was also very important to notice that with 20 milligram per kg IV infusions every 3 weeks, there was a percentage of 10% decline after 15 weeks of treatment in all patients. And in more severe cases, you can see the decline is even higher, at least 13% with dose-dependent improvement in bilirubin provides evidence for antifibrotic and anti-cholestatic activity of CM-101. Liver stiffness measurements also declined, and that also shows that there is an impact on most likely a combination of two things, which is inflammation and fibrosis, which we measure as a combination in liver stiffness measurements. The ELF score improvement was also noted in all patients. Patients with more advanced disease, ELF score improvement was higher, and the components of the ELF score, which is TIMP1, P3, and P, showed more improvement. The hyaluronic acid has not shown in this presentation. The impact as far as the clinical aspect was also on pruritus, and as you can see in both doses, there was a decline in pruritus score. So in summary, CM-101 was well tolerated, had a safety profile comparable to placebo. There was a dose-dependent efficacy as far as the anti-inflammatory and anti-fibrotic and anti-cholestatic effects. And people who had more diseases, more severe diseases, just by measurements of the liver stiffness measurements, had shown a broad and consistent improvement in biomarkers and clinical outcomes. So this is very exciting and shows that we are getting to some disease-targeted approach for management of PSC, something that has been missing for a long period of time. The second presentation was bexotegrast, which is an oral inhibitor of alpha V beta 6 and alpha V beta 1 integrin that showed improvement of markers of the cholestasis and fibrosis in PSC. This is a 24 weeks results of a phase 2 INTEGRIS PSC trial. And what is alpha V beta 6, alpha V beta 1 integrin? These basically, through stimulation of TGF beta, can stimulate myofibroblasts and cause a progression of fibrosis. And bexotegrast was an oral, once daily, dual selective inhibitor of the alpha V beta 6 beta 1 integrins, which is not only used for PSC, but also has been tried for idiopathic pulmonary fibrosis. INTEGRIS PSC study design was originally, as you can see, divided the patients to 4 treatment arm and 1 pooled placebo, but later the first arm was removed, and patients were divided to 3-to-1 with the proportions equal to placebo and also active agents, to 3 arms of 80, 160, and 320 milligrams of tablets a day, and patients with 320 were continued after week 12, and those results will be presented here. The inclusion criteria are shown at the left. Most of the patients were in the category of ELF score of more than 7.7. As you can see, transient elastography should be between 8 and 14.4. MRE was between 2.4 and 4.9, and they have to have stable IBD, and serum alkaline should be less than 10 times upper limit of normal. Primary endpoint was adverse event because this is basically a phase 2b study, and phase 2 study, and key exploratory analysis was liver stiffness, liver function biomarkers, ELF score, each NRS score, MRI, gedexotate, time to arrival in common bile duct, which is completely novel thing as far as the looking into the efficacy of the cholestatic effect of the treatments, and MRI whole liver relative enhancement. As you can see here in this slide, as opposed to placebo, which had no significant change as far as the ELF score, in all doses of bexotegrast, you can see the decline in ELF score. Adverse events were well balanced, 67% and 66% in bexotegrast as far as placebo, and no serious adverse events was noted. Overall, bexotegrast attenuated the increase in ELF score compared to placebo, and attenuated alk-phos increases compared to placebo, and improved MRI parameters. These are the slides as far as the tolerability and safety of this product, that if you can see, the ones that are related to the study drug was essentially 0%, but total serious adverse events are also very low. Bexotegrast was associated with decline in cholangitis and also pruritus at 320 milligram dose. It was also associated with decline in alkaline phosphatase over 24 weeks of treatment. You can see on the left and on the right the 12 weeks as opposed to 24 weeks. So you need a little bit longer treatment, it seems as if, to this treatment to actually have the impact. Alkaline phosphatase also, you can see, meaningfully declined after 24 weeks of the treatment. The ELF score, the percentage mean change from the baseline was much higher in bexotegrast 320 at 24 weeks as opposed to placebo, but these did not reach statistical significance. These are low numbers actually, but numerically it was higher. And there was, as opposed to participant at high risk of progression, which are ELF score of more than 9.8, bexotegrast showed improvement. Liver stiffness measurements by transient elastography shows stabilization of liver fibrosis with no change as far as the liver stiffness measurements at 24 weeks. Kind of expected the duration of the treatment should not be impacting much, but in placebo, you can see that it has increased. As far as the MRI parameters, which is something novel that you're looking at, you can see changes from a baseline as far as a gadoxetate relative enhancement. The enhancement has increased after 24 weeks. And also, as far as the time to arrival to common bile duct, it also decreased. It means that it actually moves faster through the biliary tree, and therefore it could be considered as a surrogate marker of improvement of cholestasis. As far as the itch score, also there is some improvement that you can see at 24 weeks compared to placebo. So bexotegrast 320 milligrams was generally well tolerated up to 40 weeks of treatment. Discontinuation rates were low. No serious treatment emergent adverse events were reported that were related to the study drug. Pruritus and cholangitis was observed less frequently. Shows improvement in alkaline phosphatase and stabilized symptoms associated with cholestasis compared to placebo, and potential antifibrotic effect, which is manifested by liver stiffness. ELF score and MRI measures were presented. So, and at this point, we have two good potential treatment options for this very unmet need of treatment for patients with primary sclerosing cholangitis, and that was very exciting. I want to finish the talk with three posters that all three of them also presented as late-breaking posters. One of them was the impact of elafibranor on fatigue, patients with PBC, that they looked at fatigue as one of the health-related quality measurements through the 3 different questionnaires, it's very difficult to measure such symptom. And they showed that majority of the patients who had medium to severe fatigue have had improvement in their scores through all 3 measurements. This poster was presented for a long-term effect of elafibranor, Elevite, to 3-year trial. This agent was recently approved for the treatment of patients with PBC, and we will constantly get these outcome measures on an annual basis in our meetings. And this slide also shows that the serum alkaline phosphatase normalization up to about 39%, and also compound biochemical response of up to 80% and higher were noted after 3 years of treatment, and efficacy in improvement of pruritus was noted at the right bottom side. And finally, this is the seladelpar up to 3-year data with ASSURE study, but this data was only presented for 2.5-year results or 30 months. That shows that normalization of serum alkaline phosphatase continues to persist, which is one of the major markers and also targets right now for treatment of PBC, with up to 41%, and also normalization of ALT persists. You can see normalization of bilirubin continues, and composite outcome as far as a biochemical response of over 80 percentile were noted after 2.5 years. So for that, I appreciate and thank you for the opportunity to being able to present this data today. And I'm available for any questions.
Thank you, Dr. Borg, for that excellent AASLD update. Just want to see if anybody has any specific questions pertaining to cholestatic liver disease.
Yes, Tobias here. I was just wondering, on the basis of this available information, particularly with PBC, do you think the days of the 1.67 times alkaline phosphatase objective are gone, and that PBC is now going to turn into a 2-drug treatment disease in which the ultimate objective will be the normalization of the alkaline phosphatase? And I think maybe when these patients are followed for a very long period of time, it'll turn out, maybe you think that the alkaline phosphatase normalization probably makes things work out better in the end. And as to PSC, that is just marvelous to see something being done in the vancomycin trial for PSC. And this is very exciting, since it's a frustrating disease which we had no treatments for.
Yeah, I agree with you. I think that we have to also have an individualized approach to treatment of PBC. I always tell my patients and my students that you can't actually push too much the envelope for every single patient. Some of the patients are older, and they have low liver stiffness measurements consistently in follow-ups. Even if the mild elevation of serum alkaline phosphatase will not change their outcome. We have actually studied that this normalization of alkaline phosphatase probably should be pushed on younger patients with more advanced disease that are at high risk for the more complications of the end-stage liver disease. But as far as the PSC, I agree. We have come such a long time on multiple treatment options that failed and had no impact on the outcome. Hopefully, these 2 treatment options will show some impact as far as the outcome, because it's going to be very challenging to show the outcome for these patient populations, obviously, as any other chronic liver diseases, but particularly in such rare conditions.
Dr. Walker, I have a quick question. So the fibrotic pathways in cholestatic liver disease is completely different from non-cholestatic liver disease. Now, in these studies that looked at ELF and transient elastography in such a short time, do you think that truly reflects the response to treatment?
That's a very good point that you're bringing up, and that's the reason that when I saw the MRI gadoxetate kind of studies as far as the enhancement of the showing the increased enhancement of the liver and also improvement of the flow, maybe those are going to be more important rather than showing the ELF score. You're right, ELF score has not been validated for patients with cholestatic liver diseases. So we all know also that a lot of these surrogate markers like transient elastography may also not totally reflect the underlying pathophysiology that is causing the cholestatic liver disease. Is completely different from each other. So, but the question is that are we going to biopsy these patients and at the baseline and follow them, or are we going to just rely on surrogate markers? This is going to be a challenging decision for patients with PBC. I cannot convince my patients with PBC or PSC to go frequent liver biopsies, even in the clinical trials that we had.
Thank you. For the sake of time, I'm going to hand it over to the next speaker. Thank you very much.
Thank you.
Thank you, Dr. Borg and Dr. Pagla, both of you, for that wonderful session. May I now invite Dr. Hillel Tobias. Dr. Tobias is a director of hepatology at the Northwell Lenox Hill Hospital and a professor of medicine at the Hofstra School of Medicine. Dr. Tobias, over to you. You can introduce the next speaker, Dr. Robert Kiss. Thank you so much. And then take over the session.
Yes, thank you, Sanjay. It's a pleasure to introduce Dr. Gish, who's an outstanding member of our medical community in many ways. I think he has innumerable titles, and the biography is pages long, and it's getting close to 10 o'clock. But I think some of the outstanding achievements, he's the medical director of the Hepatitis B Foundation. Is professor of medicine at multiple medical schools. And I think the most important is he is one of the members of the medical community that has been incredibly instrumental in getting public health measures accomplished in treating and evaluating the diseases that he's most interested in, one of which is hepatitis B. And this has been around the world in Asia as well as the United States. He also is unusual in that he's both interested in, obviously, medical research, 700 publications, and at the same time carries on active treatment of patients in multiple clinics around the western part of the United States. I think he's recognized as one of the experts in the field of hepatitis B, and I think it's really good to have him speak on this subject because hepatitis B is one of those diseases that I think has been totally underserved by the AASLD. The guidelines were published in, I think, 2016 or 15, and then updated in 18. And they're still years and years and years behind the guidelines from other countries, especially the guidelines from China, which has the most cases. And this is a big disease in the world at 2 billion people, and it's got over 2 million people infected in the United States. And generally, less than 2% of the people are under treatment for this disease, which leads to cancer and cirrhosis. So it's really a pleasure to introduce Dr. Gish, and hopefully he'll give us some insights to the fact that maybe the AASLD has finally made some progress in dealing with hepatitis B. Dr. Gish?
Thank you, Dr. Tobias. That was a great intro. I appreciate it very much. And I don't know if I post my slides or do you have those on your side, Sanjaya?
You share your slide.
Share mine, okay. Sit tight. Get things organized. And am I on full screen?
Yep.
Okay, fantastic. So the hepatitis B world is, I think, unjustifiably complicated. As Dr. Tobias was highlighting, the hepatitis B guidelines are lagging almost a decade behind the current data. And also there's been 2 guidelines published in the last 2 years. 2022 are the Chinese guidelines. And then just this last year, during the AASLD meeting in Kyoto, WHO released their guidelines. And these are both much, much more liberal. If you look at the Chinese guidelines, if you're over 30, you're DNA positive, you should be on treatment. WHO is a little bit more complicated with a 2000 DNA cutoff. But if you look in the fine print of those guidelines, you could almost treat anybody. Family history of liver cancer, increased fibrosis. There's a number of other markers to think about starting treatment. In HIV, we treat everybody. Hepatitis C, we treat everybody who's active infection, NAT positive. Hepatitis B, we have these inordinately complicated guidelines. I think they serve research well, they serve academia well, but they aren't serving our patients. And that's the whole point from the Hepatitis B Foundation. Point is really taking this treat everybody approach.
Bob, I think your slide's not moving.
Yeah, I'm not moving them yet. I'm
Okay,
giving
okay. Just want to make sure.
Yeah, this is like the big picture of what's going on in hepatitis B. In the last 20 years, the death rate from hepatitis B has not changed. It's 2 people dying every minute. So we've had probably 16 different guidelines published from different organizations, multiple phases of those guidelines, and there's no impact on the mortality. So I think we can say that the guidelines have failed us until more recently. Hillel and I were corresponding by email last week, and the AASLD is going to come out with new guidelines, but they are following the highest guideline requirements, the PICO, the highest level of evidence. And then each PICO question costs money. So they have a limited budget, so they're only going to have a small number of questions they're going to answer. And then there's guidance, and then there's expert opinion. And it's a little bit liquid inside the AASLD, whether they're going to actually allow guidance documents or they're now going to call them expert opinion documents. So as the vice chair of the Hepatitis B SIG with Calvin Pan, we're going to try to move the dial on this to have both guidelines that fit WHO and all the highest level of evidence, and then either guidance or hopefully expert opinion documents that will really help us every day and really help our patients more. Now let's see if I can get the slides to advance. A little bit more information. My website has extensive resources for you, PowerPoint, recorded sessions, podcasts, a lot of things going on as we try to spread the word about the hepatitis B world, really that we call the 5-line guideline, which we've published in 5 different publications, make this very, very easy and simple. And we think that is in harmony with the WHO elimination plan. If you have complicated guidelines, no one gets treated, you can't meet your elimination goals. So let's talk a little bit more about this hepatitis B world, why things are so complicated. And what happens is we have these different phases of the disease, and there's still this issue about immune tolerant, which is an out-of-date term. The patients are not immune tolerant, and EASL has done better with this chronic infection versus chronic hepatitis and E status. But in the NIH study of hepatitis B that was also published, a large number of people are in this gray zone. People don't like that term gray zone anymore, especially because we're finding out that these patients in these indeterminate zone, their viral load may be less than 2,000, less than 20,000, ALT elevated, but doesn't meet the 2 times upper limits of normal trigger to think about treatment. These patients are having bad outcomes. They are having higher risk of cancer specifically, but also of risk of progression. Many of these patients on biopsy or advanced imaging have significant fibrosis. So these patients in this indeterminate phase or gray zone phase have a low probability of S clearance and a higher probability of serious outcomes. The more and more data is accumulating to think about treating everybody. And what the guidelines don't include is stigma, discrimination, other types of cancer. They discuss briefly other extrahepatic manifestations of hepatitis B. They don't even touch on quality of life. And of course, there's a variety of other issues with hepatitis B that really affect that individual patient's outcome. Can they get a job? Can they get married? So we are really thinking about this simplified approach from the Hepatitis B Foundation, really thinking that the Chinese guidelines are really the guidelines that really service our patients very, very well. And we can get into the Q&A on cost issues. I'm going to move quickly through this so we can have a little bit longer Q&A, but there is very interesting information that even hepatitis B infected children can have a high rate of S loss. Now, pegylated interferon is pretty much gone from North America and Europe, but if you move to China, a large number of patients are still getting interferon treatment. There's some complex reasons behind that, but if you look at the Everest study and some of these other larger interferon studies, you can get patients with S loss up to 30%. Now, this is very dependent on having quantitative surface antigen. And I'm going to recommend in your practice every year on every hepatitis B patient, you should be measuring quantitative S antigen. It helps you with issues such as infectivity, liver cancer risk. Is somebody undergoing natural seroclearance, natural functional cure? Or are they going to be clearing S antigen on a nuke? That happens in 5 to 10% of patients. Or if you stop the nuke, what's the chances of S clearance? And it's very useful in the interferon space as well. So quantitative surface antigen, in my opinion, is the standard of care, should be done annually. It's easily available through any reference lab, pretty much anywhere in the world. If you're in even low-income countries, have Roche or Abbott platforms where you can get quantitative surface antigen. So a little bit more here about pegylated interferon. Durable S loss in over 30% of patients. Again, these patients, this type of data shouldn't be saying you're going to use interferon in your practice today. But if you want to be aggressive and add interferon to your management of patients, you need that quantitative S profile. S below 100, those have the highest probability of clearance with interferon, specifically in Asian patients. In adult-acquired hepatitis B, under 1,000 IUs for surface antigen indicates a chance of clearance with pegylated interferon. But I'm going to say interferon's not quite ready, excuse me, for prime time back in our practice yet, but you're going to be seeing momentarily a number of research studies that look at the issue of interferon in combination therapy. Now, one thing I left out of that list of 7 reasons to treat everybody is infectivity. And most important, infectivity is mother-to-child transmission, but infectivity is sexual transmission, household transmission. There's other issues about why we need to lower hepatitis B DNA levels to decrease infectivity. And of course, clearing S antigens are our ultimate goal. I'm going to talk about a couple of things about mother-to-child transmission. First off, TAF is as safe as TDF in the setting of pregnancy. This is safety for the mother, safety for the baby in utero, and safety for the baby after delivery. Now, if you give the mother TAF, and this is what's recommended now in WHO guidelines during the 2nd trimester, as opposed to the 3rd trimester, specifically in high viral load patients, but if you don't have access to viral load, just treatment with TAF during the 2nd and 3rd trimester until delivery in combination with vaccine probably can eliminate HBIG completely. Now, in first world countries, we have lots of HBIG. It's covered by insurance, easy to administer to that baby at birth with vaccine. But hepatitis B immune globulin in most of the rest of the world is quite expensive or no access. And we're really seeing data from here, Calvin Pan's work, other work, including Jourdain, the one that was in New England Journal a few years ago from Thailand, that HBIG is probably not needed if you're aggressive with nuke therapy during the 2nd and 3rd trimester, and you vaccinate the baby within 24 hours of birth. Gavi wasn't covering birth dose vaccine until a phase-in starting over the last 1 to 2 years. And without that birth dose vaccine, you cannot provide neonatal protection for your infants. I'm now going to move through a number of different studies that are in combination. This is Veer's study combination with now 3 drugs, and actually 4 drugs because these patients are nuke treated. But there's a monoclonal antibody, siRNA, adding interferon therapy in nuke suppressed patients. So this is really the model I've been talking about for quite a bit of time, which is a 4-drug combination. I think it's going to take 4 drugs if you want treatment to be 12 months or less, and you want to have S loss rates that are in the 30 to 40% range. So we are getting closer to this now in these phase 2 studies, showing that after 48 weeks of therapy, high rates of S loss that are getting close to our target of 40%. Now, what's going to be important is the durability of this S loss. The BEPI study from GSK, which is an ASO and antisense oligonucleotide, had about a 50% relapse rate once they stopped all of their therapies, including stopping the ASO. So really, off treatment, S loss, DNA negativity is going to be key. Most of us believe that you need to see it not just at 6 months, but at 12 months to say that this is truly a stable off-treatment functional cure. But now with this over 30% S loss rate is quite impressive. And in these cases, S loss also is equal to HBV DNA negativity. Now we're going to be getting into a little bit more interesting data here about another siRNA, imdusiran. This is given every 8 weeks combined with a nuke, and then a delayed course of 24 weeks of interferon. So you're going to keep hearing this interferon story coming back and back to us. Interferon still is alive and well. It is an immune modulator, has many, many different intracellular, intrahepatocyte immune activity. And this is imdusiran plus 24 weeks of interferon, well tolerated, and have a functional cure in up to 50% of patients under 1,000. Now you have to say in your practice, how many patients have S antigens under 1,000? There's some good data that GSK showed in a manuscript, at least a poster, 2 years ago. And about a third of patients are under this 1,000 in a broad-based patient population. I'm still looking into that in my practice because I've ordered quantitative S in one of my federal clinics in over 300 patients. And I have a number of patients whose quantitative S is over 25,000. So these really, really high S patients are probably going to require something new and novel. And we'll get to that in just a little bit. All right, so let's move on to this VTP 300. So another part of this world is using therapeutic vaccines. You want immunotherapy, you want to be eliciting both T and B cell response. This was actually combined with a checkpoint inhibitor that we've used historically for HCC and a variety of other cancers. But there is clear evidence that these co-stimulatory immune factors are part of how hepatitis B manipulates the immune system to allow persistence. And now, by putting a foot on the accelerator and taking your foot off the brakes, you can have very, very substantial S antigen reduction. And we're hoping that this can be part of our future cure pathway. So immunomodulator is going to equal interferon, therapeutic vaccines, monoclonal antibodies, which a number of companies are working on. There's just many, many things going on, including therapies in the TLR space. I'm going to now talk about Delta for just a moment. I'm going to step back and say Delta is an under-tested and under-recognized disease. But in the US, there's been a big controversy with the FDA because a number of companies have been turned down for orphan drug designation for new Delta treatments. And the FDA was basing this on 3 manuscripts, one of which came out of the NHANES group that was published by the authors from Johns Hopkins, and using this 42% number in one paper, lead author Patel, who worked in David Thomas's lab, they were estimating that hepatitis delta in the US was 250,000 actively infected delta patients. Now, this paper is undergoing serious modifications, maybe even retractions, and that's in process right now because the assay that they used was, we believe, and this was signed by a large number of co-authors, to be terribly inaccurate. If you use data from Robert Wong and work that I've done, also from Homi Razavi and a number of other important authors, that we believe Delta in the US is somewhere between 60 and 80,000 individuals who are actively infected, meaning Delta RNA positivity. Let's talk about Delta RNA positivity for a moment. In your practice, you may have difficulty getting Delta RNA quantification. Roche is working on a global platform on their newer machines to be getting hopefully either WHO or FDA cleared, what's called WHO pre-qualification. But both Abbott and Roche platforms, at least from an RUO research use only, do have significant ability to measure HDV RNA quantification. There's other laboratories in this world, Robogene, there's probably 7 other labs that have Delta RNA quantification that look reasonably accurate. In the US, Quest has offered Delta RNA quantification for about 7 years. AREP has offered it for over a decade. Mayo came online recently, and LabCorp should have Delta RNA quantification available early quarter 2025. So when you have a surface antigen positive patient, you need to reflex to Delta antibody total, not IgM, not Delta antigen. Those 2 tests are out of date. If Delta antibody is positive, you need to reflex to a Delta RNA PCR quant. And in my opinion, that is the current standard of care. There's quite a bit of data here that's emerging from different parts of the world. This is the country of Georgia on the left, Canada in the middle, USVA on the right, that Delta positivity first by antibody testing and then by PCR testing is in the 3% range. Now, if you have Delta antibody positivity, there's studies as low as 30%, studies as high as 70% of antibody positive will be Delta RNA positive. That doesn't mean it's a false positive. That indicates the Delta antibody is a true positive, but a subset of people have cleared their Delta RNA. And this gives us great hope that Delta is actually going to be curable, or what we call maintain virologic response. That means once they clear Delta RNA on therapy or naturally, they maintain Delta RNA negative long term. There is a great move to be bringing this reflex testing to be automated. You check a box and it moves through this double reflex. And I am working with Hepatitis B Foundation actively to get this double reflex system available through AREP, Quest, LabCorp, and hopefully Mayo Clinic. This does improve testing in these patients. Now, bulevirtide has been fully approved in Europe for chronic treatment of Delta. There's a huge amount of data that has emerged, but this is Delta RNA suppression with maintenance daily injectable therapy. This is not looked at alone as a cure for Delta, except in a distinct minority of patients. There was some data that was published at this meeting that showed that if you stop bulevirtide after prolonged treatment between 2 and 4 years, you can maintain viral suppression in the 15 to 20% range. But we have clear data that this medicine is safe. The only really side effects is occasional local injection site or increase in bile acids, but those bile acids have not been deemed to be pathologic. There's no evidence of cardiac toxicity from bile acids or nor itching. So this is really impressive that we have improved quality of life. We have decreased de novo liver-related events during bulevirtide monotherapy, and we've got data out stretching towards 5 years. So bulevirtide in the US is still being reviewed by the FDA. The FDA had no issues with the efficacy. They had no issues with safety. They did have issues with manufacturing, and manufacturing has moved from Germany to the US. That is now being cleared. And the final path to get bulevirtide, in my opinion, this is not anything that's been published or I've been told by Gilead, but in my opinion, it has to do with the injection process. In the complete response letter, there were concerns that patients would not be able to manage the admixture of the bulevirtide as a powder, mixing it with sterile water, and then bringing us back to another syringe and doing the injection process. I do have one patient on bulevirtide in my practice. It took me about 20 hours of my time, 20 hours of my assistant's time, interaction with Gilead, my IRB, and the FDA to get access to drug to one patient. But this patient is very happy, actively playing tennis every week. So a little bit more data now about moving into the Delta world with combination therapy. We're now back to what we talked about earlier, using a siRNA and a monoclonal antibody with incredible results. A reduction of S antigen with this triple combination and this clearance and control of HDV RNA, ALT normalization has now given us the green light to move this combination therapy to phase 3 trials, which is going to start in early 2025. So lots going on in this space. Blue Jays also in the monoclonal antibody space. They have data on monotherapy showing excellent HDV RNA suppression, ALT normalization. And this is very exciting because these monoclonal antibodies, I was very skeptical on originally, but they appeared to have effects of direct viral suppression. They decrease entry through the receptor, the NTCP receptor. And then finally, they are vaccinal-like vaccinal-like effects in combination with these other effects. They actually stimulate the immune response to have this control. As I wrap things up here, and I've been, very, very giving this the 10,000 foot view. There's over 65 drugs in development for hepatitis B, and there are at least 10 different compounds in development for Delta. And lonafarnib is back. Lambda interferon may also be resurrected in the Delta world. So we've got a lot going on here in terms of managing patients. Really, you need to think about 4-drug combination. You don't tell your patients they're on lifelong therapy for hepatitis B. Give them hope. Tell them that there's some very interesting medications on their way for finite therapy. And I'm going to predict in the 40% range of functional cure. That's S loss. DNA negative. Of course, if you get surface antibody, there appears to be better immune control long-term, better stable viral control, S clearance, DNA suppression, but surface antibody is not required for the functional cure. But what about the 60% of people who get this expensive new therapy in my fantasy world? They get 40% S loss. Those patients may need long-term maintenance therapy. They may need retreatment with another phase of drugs. But we do now have the future in front of us where we're going to have a much higher rate of functional cure, better patient engagement, back to guidelines, guidance, and expert opinion. I believe we really need to be moving aggressively towards a treat-all approach. We have a test-all approach, vaccinate everybody who's triple panel negative, and now we're going to be giving our patients hope to move these patients into either clinical trials or as these drugs emerge towards direct patient treatment. Thanks very much to the INEDSYS team. Sanjaya, thanks for the invitation. Dr. Tobias, that was a great introduction. I've been paying attention on these early morning hours here in California to all these other great lectures, and I think that is a wrap. Thanks everybody for staying with us.
Thank you very much. It was really very good to hear about all this.
Trying to get rid of the share screen if I can get this under control.
I just had one to ask, I also have a patient that's on bulevirtide. I think we have the only 2 patients in the country that are on it. But I actually have a couple of patients that with Delta, but all my patients with Delta are Eastern European and not Asian. I just is that characteristic of the situation?
Let's just step back. We're in a satellite. We're going around the world. The largest number of Delta patients are actually in China, in Xinjiang, the northwestern region of China. The next big concentration is in the stands. Now, Pakistan is the one that's very well known. We have great colleagues in Pakistan working actively on the Delta treatment world. But I've been working in Uzbekistan and Kazakhstan this last year. This next summer, I'll be going to Kyrgyzstan. Delta in those patients can range up to 15%. Mongolia, if you're surface antigen positive, the chance of being Delta positive is in the 50% range. So the hot spots are Xinjiang, Mongolia, the stands that border the Chinese Central Asian corridor, but that goes all the way into Azerbaijan, Georgia, and Armenia. You have a hot spot in Pakistan with very little Delta in India. Along that border between India and Pakistan, there is some significant Delta, but once you move into the main Indian continent, Delta is quite rare. And of course, we have a hot spot in the Amazonia. So this is Upper Amazon and what's called the Orinoco River Valley that goes, the Orinoco River flows north into Venezuela. There's also a number of hotspots of Delta in Africa. Dr. Tobias highlighted my travels around the world, and in April, I'm going to do the whole west coast of Africa, starting in Ghana and ending up in Senegal. I'll be teaching in each of these ports, including Liberia, Sierra Leone, the Gambia, working on these, bringing testing and treatment ideas, research ideas to West Africa. But there are countries in West Africa where there's a high Delta prevalence. Also in East Africa, the Horn of Africa, Sudan, Ethiopia, Eritrea, Djibouti, there's a lot of Delta as well. So Delta's got hot spots all over the world. It hasn't been fully explained why it's in these places and not in others. But yeah, that's the global view. Sorry for the elevator speech.
Manhattan, it seems to be Eastern Europe. But they're going to also have to do something about the preparation. My patient who's taking this it was a nurse who has cirrhosis and was able to manage injecting every day with that powder. That's not going to fly on any national or international basis. It's hard to. And the other thing is interferon. These other patients I had with Delta have responded 2 years of interferon. The last one has been negative for 2 years now since then.
Nice. I do want to comment on this preparation issue. I think Americans are wimps. There's 4,000 people on bulevirtide in Europe right now, and I've surveyed all of these docs. This is Dr. Buti, this is Pietro, Heiner Wienermeyer, and Michael Mans. I just go down this giant list of people, our French, our Parisian colleagues as well. And they say their patients have no trouble mixing this up and administering it. So I think we maybe baby our patients, but the FDA has already taken this track. We will have a simpler way of injection.
Yes, it's always a pleasure listening to your talk. And I have a quick question to ask you. So the curative indicator for hepatitis B is more the hepatitis B surface antigen titer more than the viral load? Is that what
it's an integrated, Manjesh, you need to think about quant S and the DNA level as a composite, because the DNA level has this direct effect, as you know, on cancer risk, death, transplant, cirrhosis, but surface antigen can be superimposed on that. High surface antigen, low DNA level, much higher risk of hepatocellular carcinoma. In women who are in a gray zone, let's say their viral load while they're pregnant is 100,000, that's below the 200,000 threshold for TAF or TDF. But if they have a high surface antigen level, suddenly they're moved into a higher risk of transmitting to the baby. So it's a composite. There's no one single test. You got to look across all of our tests and make your decisions about treatment and risk.
Thank you.
Thank you. Dr. Tobias, we would like to conclude the session, but before we do the conclusion, I would like to invite all the moderators and give a few final word of wisdom, and then we'll conclude the session after that. So, Dr. Jalal.
Yeah, thank you, Sanjay, and all the speakers and the attendees for very interactive, wonderful session. My first session I started with is HCC. What I again learned is that non-viral HCC is a big problem, is increasing, harder to treat, delayed presentation. And I think one area we probably is evolving is neoadjuvant therapy or immunotherapy before transplantation. Then that area we need to watch the space. But otherwise, everyone did a fantastic job. I have a question to related to alcohol liver disease, if I may, with Anand's presentation. So based on your presentation, I mean, obviously you mentioned infection. I mean, how significant serious infections with the minor infection are serious enough to be hospitalized? And secondly, whether it's a stepwise or steady dose, I mean, I most of the time use stepwise anyway, step down, but does it make any difference over the outcome? So in terms of comparing compare steroid versus non-steroid group, did you find any difference? Anand is there?
No, Prasoon, Dr. Anand has left. I think I would like to just give your final conclusions right now.
Okay, all right. So again, that's my conclusion about the HCC part. Thank you.
Yeah, thank you, Dr. Jalal. Dr. Pagdala.
So thank you, Dr. Satpathy, for arranging this wonderful presentation and all the speakers for the great insight. My conclusion remark is I think this is really exciting times for hepatology. I mean, we are now talking about, before this, we just had treatment for hepatitis C, but now we're talking about fatty liver. We're getting into, treatment of PBC. And now it's nice to know that there's so many drugs in the pipeline for PSC. And also, importantly, we're talking about curative therapeutics for hepatitis B. So I want to conclude by saying that I hope our next presentation would be more about curative aspects. And that's what I'd like to see hepatitis, the field of hepatology go towards. Thank you very much.
Dr. Tobias.
Yes, thank you. I also want to echo the real usefulness of these presentations and the reflection on the fact that the AASLD papers are moving in a different direction. After the cure of Hep C, there was sort of a hiatus for several years in which nothing much was happening. And the fact that we're moving along in the treatment of fatty liver cancer, cholangitis, I think this is the beginning of a new era, and I think the papers presented today certainly illustrate it.
Thank you. And finally, I would like to thank you, everyone who attended this session today and stayed so long to the end of this meeting. And also would like to thank you, the speakers and the moderators, for doing such a fantastic job. I think this was the first time INEDSYS organized an AASLD highlights, and this was, I'm really amazed at the way the audience were engaged and stayed so throughout this session. So thank you again. Thank you, everyone. We look forward to see you in 2 weeks again.